I'm Mauricio Towen, and it is my pleasure to introduce today's speaker, Dr. Hamilton. So Dr. Hamilton is the medical director at MDC, Metropolitan Detention Center, and he has been doing this for the last 18 years. So after college in New York, he moved nearby to Texas, where he completed his medical school training and residency in psychiatry at the University of Texas in Houston. And as mentioned, 18 years ago, he moved to New Mexico. I gathered that the initial interest was not necessarily MDC. It was another facility, not UNM. But then he started working at MDC part-time, and then he decided to stay full-time. And he's been at MDC again for the last 18 years. I've had the pleasure to meet Dr. Hamilton. Actually, I think the first time we met face-to-face is when one of the first times is when I visited MDC. And I was very impressed on how he was received by the inmates / patients. I could see them trusting him, and there was affection actually on both sides. I was very impressed. Now, we've been at MDC in the past, actually before my time, and then UNM left, and now we're back. And I think that is the best thing that we can do for the community. Again, UNM, we serve the New Mexico community, certainly Bernalillo County. And as I'm sure you've heard me folks, many times, really MDC is part of our system of care. I like to experiment things firsthand. So I'm there at least once a month on a weekend. It's not the same thing as being there all the time. But what I've learned is that that was a part of the treatment that we were missing for our patients. Unfortunately, many of them, many of our patients, many of them actually end up at MDC. I would say that in terms of those who are incarcerated and also need psychiatric care, I would say more than 80% we have seen them at PS. I've seen them, or our inpatient unit. And this is part of the revolving door. Once they're released, if they don't receive the needed psychiatric treatment, they're gonna commit a misdemeanor, well, I suppose sometimes a felony, but for the most part, trespassing, things related to drug use, and they end up back. And one of the reasons is because of the continuity of care, that ideally once they're released, and then they can be released right now or in the middle of the night, and if they don't have follow-up, it's going to bring them back. So I think this is a great thing that all of you working at MDC and UNM are doing. It's great for patient care. Now, it has its challenges, I can tell you, and I'm sure Dr. Hamilton would talk about it in a moment. Just a simple one. There's staffing shortages. So sometimes giving medications 3 times a day is a challenge. There's not enough folks, but so we need to adapt to it. But let me stop. And again, Dr. Hamilton, it is a pleasure to collaborate with you. And again, congratulations for all the work that you do for our community. Dr. Hamilton.
Thank you. I'll go ahead and share my screen now. So thanks, Dr. Towen, for the introduction. But I came here to New Mexico like a lot of people come here to Mexico, and that's just because New Mexico is a beautiful state. So I'm a big outdoors person, hiker, I have horses. And that was one of the things that drew me here. And I think that's one of the things that'll keep me here. I have these 2 goofball horses. I think they both have personality disorders. They fight and drag each other to the ground. I live out in Harris, and I have some interesting neighbors. One of them being this big guy. He's like 400 pounds. He's amazing. But so I came here for New Mexico. I started working out here at the jail part-time to full-time. So like Dr. Toan said,
Dr.
pretty
Hamilton,
soon.
are you sharing slides or not?
Oh yeah, can't see him? Let me fix it.
No, I cannot see them. If anybody else can see them, raise your hand.
No, oh yeah, the circle went off.
There's two clicks at the share.
Okay, so let me get back to my sharing here.
Because when you said the 400 pound, I was waiting to see something.
Sorry.
There we go. We're
There
good.
you go. Okay. Yeah, sorry. I got to get back because I got to show it off. So these are my two goofball horses. So you
There
can
you
see
go.
those. Yes?
Yes, yes,
Okay.
we can see them.
Sorry. It's just I can't see the outline. And then
Yes.
here's my neighbor here.
Oh, okay, okay.
All right, so what I'm going to do today is talk about in general about MDC, and I'm hoping that to leave time for questions after. So if I pass over something that you don't really understand about the terminology or something about MDC, I mean, my problem when talking about MDC is that I could talk to you for hours about MDC. So I've tried to condense it, had to leave some things out. So again, if you have any questions at the end or text me and I can answer your questions. So out here, we're known as PSU, the Psychiatric Services Unit. So you'll see PSU on our offices and our units. And in general, our overall population at the jail runs about 1,800. 1,950 is our cap. And this past year, we were at 1,950 for a while. And I can talk about the reasons why we're up so high. So this year, our average has been above 1,800. So we do about 2,100 intakes a month. And so we screen and see a lot of people. And then about 800 people right now are on our caseload. We run between 45, 50% usually on our caseload. We have about 180 patients with serious mental illness, and serious mental illness is listed as schizophrenia, any other kind of psychotic disorder, bipolar disorder, major depressive disorder, and then anything requiring clinical exclusion or suicide watch. So you could have somebody that doesn't normally have a serious mental illness, maybe they're intoxicated, like a meth psychosis, they're labeled SMI, and then when they clear, it's changed to not SMI. But we use a definition put forward by our federal monitor, which I'll talk about in a minute. So when I did this count, we had 128 people on our specialized mental health units, and that's spread over 4 units. So we run about 30 a unit. And then we have 15 up to 30 suicide watch and seclusions to see a day. And those are you have to see those every 24 hours. And then we appointed 25 treatment guardians I did this for last month. So that was pretty significant. And then we are sending from 3 to 32 certificate evaluations to PES a month. So those of you working at PES, I know have felt this on some days when, we're sending, 2 people and then 2 more people and then 2 more people. That has to do with how patients are released here. We're not allowed, we can only keep people for 24 hours. So we also have one psychiatric medical director, me, 7 other psychiatrists, 1 psychiatric nurse practitioner. We have a mental health director who's a psychologist. We have 19 PSU counselors, 6 psychiatric nurses, 6 discharge planners. So we have a pretty significant staff. So we've had a big increase in our overall population since UNM took over MDC. In 2023, we started off about 1,200, and we've since gone to, again, 1,800 and above. For 2023, we would go up to 1,400 and then slide back down to 1,200. But now we've held on to this 30% increase, and it looks like that's where we're going to stay. And that's important because our staffing model was made for closer to 1,200, so we're having to make some adjustments. So why has the psychiatric population increased? One of the big things for us was when they closed the homeless camps. When they made that decision about 2 years ago that was going to happen, we've seen a huge increase in the number of arrests for seriously mentally ill people with minor charges. And then what's happening is they get booked, they get released, but with a court date. They don't show for court because they don't have a phone or a calendar or anything, and then they have a warrant, and then they get rebooked. Well, then it's a nonviolent offense, then they're let out, and then they're rebooked. And then once that happens enough times, they're being held over for a competency evaluation. We also see on the news a lot the increased policing of Central. Well, unfortunately, that corridor is where we find a lot of our unhoused patients. And then we always get a huge increase when it's Balloon Fiesta or State Fair. And unfortunately, the population then doesn't just go down right after, because so many of them then have to stay to deal with their many warrants. So here we have multiple program pods. So we have our psychiatric acute care for seclusions and suicide watches. We have RHU6, which I'll talk about what that means for seriously mentally ill male patients with a higher security requirement. RU5 is for SMI female patients with a higher security requirement. We have FOX2 for SMI male patients that are kind of intermediate, step down from RU6. Delta 3 is for residential men. And again, I'll explain this further in a minute. But all of the program pods have a counselor, a psychiatrist, and the psychiatric nurses go to those pods every day. So they do things like if a patient has refused med pass, they go back to the unit to offer them meds again, which really improves compliance. So I do have to say, a little bit about that we're under the McClendon settlement agreement, because it does affect a lot of the things that we do here. So it's a lawsuit that started in 1995, and it covers all of the psychiatric patients at MDC. So all of the patients here have an attorney or a group of attorneys to reach to, the McClendon attorneys. So there are specific requirements under McClendon, and one of them is that for every 100 patients on the caseload, we have a psychiatric provider, and that all referrals to psychiatry from intake are to be seen within 24 business hours. And all patients on medication have to be seen at least every 30 days. And our federal monitor comes every 6 months. So that means I started my first federal monitor visit was in the end of 2008. So I've seen him every 6 months for a long time. He's great. He's a psychiatrist. He actually helps. He's helped organize our system, and he's coming again. So the first McClendon monitor visit after UNM started MDC in July of 2023, I used several different words to describe it, but I settled just on a sad, crying face. Our first visit, we weren't organized, and part of it was because Cerner wasn't set up to track everything, and I just have to say it was a mess. But our most recent federal monitor visit was the most organized and complete in the past 17 years, so ever that I've ever experienced. And we had a significant increase in overall compliance. It went from 25% to well over 50%. And some of the areas that we're not compliant in have to do with security staffing. So Dr. Metzner finally said, hey, I think you guys are getting close to getting out of this after 30 years. So it was again, our best visit ever. So prior to UNM coming here, the medical and mental health was managed by private companies. So, and those contracts would be every 3 years. We did have one company that did really great and had an extension, but we also had companies that were terrible and lasted 1 year. And a big downside to that is that you lose staff every time you change contracts. So if you think about in the past, I think it was 6 years, 5 years, we had 3 different companies. We lost a lot of staff each time. The county commissioners and a panel choose the companies, and we were choosing companies with poor track records just because they gave the lowest bid. And then the kind of people that they would send out here to help manage were people that didn't have a lot of experience. So with UNM, we're not changing. This is going to stay UNM, and we're going to be able to retain more staff in all areas and give more consistent quality care. So there's a lot of opportunities out here for residents and medical students. And I saw Dr. Shed is on. She currently has a 4th-year medical student. So residents and medical students can see lots of acute care, suicide watches, clinical seclusions, people that need emergency medications, people that need IMPs and treatment guardians. And then we have the intermediate level and then the residential level. So it's kind of like inpatient to outpatient. But the good thing with our outpatient is that they're here, they're sequestered, and it's forced sobriety, and you know their med compliance. So we can actually see how well they're doing and have that knowledge that what their med compliance is exactly, because it allows you then to make a more informed decision. And the other thing about being here is there's long-term patients on all of these levels. There's some long-term patients that have to stay on acute care. And there are patients, honestly, that everybody that's worked inpatient at UNM knows, because once they're inpatient at UNM, they're there for long periods. It's the same when they're here. They're here for long periods. But, one of the great things is while they're here for these long periods, we get to do different med trials, different med combinations. Then we get to do things like get them full guardians. And I have seen patients that were here on our units for the long term, and I mean 2 years plus, and they have improved so far beyond what I thought they could have improved to. From all the records I have, all the years I've seen them in and out, to see them here for that long, again, we know their med compliance with forced sobriety. They don't have the housing stress. I've seen, to me, what seems like an honest miracle. Like I am looking at them And I think in my head, this is a miracle. This is amazing. I know it's the medication and the situation, but they regain so much in their life. They're able to leave here and maintain, in a group home, reconnect with their families. So we do see amazing gains. And these are unfortunately people who get serious charges, get caught up in competency, and we have had them on our units 2 to 4 years. So another interesting thing about being here is the interaction with the patient's legal teams. So several things surprised me when I first started working here, and that was when I would talk to an attorney, the attorney wouldn't know the legal aspects of competency and how to deal with somebody who is seriously mentally ill. So unfortunately, we sometimes have to do the education of the attorneys, like, hey, you need to raise competency. Why do I need to do that? Well, they can't talk to their attorney, they don't understand their charges, and they're disorganized, psychotic. So then we get them to file the competency. And I've learned we have to do that early because sometimes it seems so obvious that I didn't do that, only to find out later that the attorney didn't know they should do that. And then it delays the case another 6 months. So something that Dr. Shed and I do is we talk to the competency evaluators. The reason we do that is because part of the order on competency is the legal order is that they must review with Dr. Hamilton and another one of the providers to see what their current level of functioning is at MDC. And this is because we were getting too many cases of there would be information that was out of date by the time it came to court. And by doing this, we also help the evaluators finish their report so they can get the report in, the patient can get to court and it can get decided, and a lot of times they can be released. So there's been periods where we were waiting on this for 6 to 9 months, and now it's down to under a month. Somebody came in 2 weeks ago, they've already had their evaluation. And then they'll talk to Megan or I, and they'll be able to write the report, get it in, and get it done. And usually for these patients, get them out of jail. The other thing that we get to do is testify as a fact witness about the patient's level of functioning in these contested competency cases. And I wouldn't say enjoy doing this, but it was a very important thing to do, because if you have a patient that was found incompetent, goes to the state hospital for restoration, and then they're found competent, they come back, and it's obvious that they're incompetent, it just wouldn't be justice to allow them to go to a normal hearing without any presentation about their mental illness. So it's a famous case, somebody that murdered a bunch of people, incompetent, then competent, came back, found incompetent by a local, somebody that visited him here at MDC as opposed to state hospital. It turned to kind of an ugly battle. And then finally I had to appear in court and say how he was functioning here. And basically it was, like aliens and CIA and FBI, and he was obviously incompetent. So now he's back at the state hospital as opposed to prison. So to send somebody to actual prison, DOC, that is chronically severely psychotic, they would just be in segregation at DOC. You have to imagine that. A schizophrenic, completely delusional, in segregation, almost no other human contact. It just wouldn't be justice. So we also get to testify in sentencing for the purpose of mitigation. So for patients that maybe weren't incompetent, but that had impairments that may have led to their bad decision making, I do like it that the court will let us will listen to us and can actually adjust their sentencing. It's also good for the family of the patient to hear, and also the victim to hear that this happened when the patient was highly impaired. I will say that a lot of people don't like testifying, and I'm one of those. I don't like testifying. But when you're doing it for such a good cause that can make such a difference in the legal outcome and the rest of these patients' lives, it is well worth doing. So I want to talk a little bit about working with security here at MDC. I will have to say that it's been says caused some of my most difficult days, but it's also one of the reasons I still work here, because we work with a lot of really supportive MDC administrative security, from the deputy warden, wardens, multiple majors, captains, and on down. They are very concerned that these people get the treatment that they need. And then when new officers start here, they all get a week of specialized PSU training. And we talk a lot about the different specialty units and how to approach and deal with patients on the specialty units. We talk about their diagnosis and their treatment. And then we also talk a lot about how to do referrals when you see somebody not doing well and they're not on a psych unit. And then every 6 months, officers who choose to work on one of our mental health pods has an 8-hour refresher. And that's very important because I've got people in that refresher that have been there with me in that training for, over 10 years. And then we have new people, and it creates, kind of team building. And we talk about all of the difficult cases, and we talk about how to deal with the mental health staff versus, it's getting them the best treatment, but also worrying about safety. So I find that training is really, really beneficial. So the other thing about this training and ongoing training is the significant culture change that I've seen happen here over the years. So officers now they don't hesitate to call for mental health. They want them to get the treatment. There's more awareness about mental illness and the symptoms and how they can be victimized on general units. And the slide creator chose this slide with this like dumbbell, and it made me realize it has been heavy lifting to develop this change in a culture. But I think that it's happened, and there's no way to go back, because upper management all the way down now understands the need for the treatment and how it benefits overall jail management. So I just want to say a word about safety at MDC. Again, I've been here for a long time, and from my perspective, working as a mental health provider at MDC is safer, has been safer than working, say, at PES or inpatient somewhere or an ER somewhere, because we get patients from the different hospitals that have hit a nurse or a counselor or a doctor. So out here, I can count the number of incidents on one hand. 2. There's been 2 people injured here in 17 years, and they were both non-medical staff. They walked into a sally port with an agitated patient, which we don't do. We don't go in sally ports with inmates or patients. They weren't paying attention and they were injured, but that's it. Two times. Now, I'm not saying that I haven't heard, from a seclusion, I'm going to kill you, Dr. Hamilton. Just you wait. But the next day or the next day, they're out of that cell and they're calm and polite and thanking you for taking care of them. So, you know, of course, we have incidents where, security intervenes and somebody that's arguing with us. Security is always aware when we're on the unit, and I have stepped behind a security officer when there was an angry patient. But in general, they're so grateful to have us, whether it's the psychiatrist or the counselor or the nurse, that injuring us is the last thing that they want to do. So I wanted to describe just like how it works out here, because there is some big differences in how we're able to care for people because it is a jail. And a lot of you have read our notes from out here. So I just wanted to say some things about the terminology. Like I've been asked, what the hell is RDT? What does that mean? Well, it's where people start out here at MDC. It's receiving discharge transfer. So in a lot of our notes, if somebody needs an intake, we say that they're on the RDT list. People start in that area and then they get their assessment by a nurse who does a mental health assessment and then refers to the counselors. And they do it based on an acuity system, P1, P2, P3. The P1s have to go almost like suicide watch. They go right in front of the officers, like line of sight. And then those have to be seen either immediately or within 4 hours. And then we have P2s that are kind of in between. They're up to 8 hours. So psychotic, but not a danger to themselves or others. And then P3s. P3s are people who have had psychiatric treatment in the past 2 years, or they're just requesting to see a psychiatrist. Per McClendon consent decree, we have to see everybody that asked to see a psychiatrist. So once the patient has had the referral to see a psychiatrist, we have 1 business day to complete the evaluation and start treatment. So that's significantly different here as opposed to other jails that have up to 14 days. Here, 1 business day. We have 2 telepsych providers who see the general population, RDT patients, but many of the RDT patients go to PAC and are seen by the acute care psychiatric team, also within 1 business day. A lot of them are seen, of course, Saturday and Sunday because they're on seclusion or suicide watch. So then once they're on our units, the acute care providers are assigned suicide watches or seclusions for daily follow-ups, and those are divided out by units. And the acute care providers also each manage one of the psychiatric units. And most of the patients on the psychiatric units are seen weekly to monthly, depending on stability. So on, our highest level unit, the majority are weekly, and then on our lowest acuity, the Delta unit, they're almost all monthly. So I want to mention something that this is what's really different about working in jail, that these people have a security classification, and that classification can determine where they go in the jail. And this can cause some frustration when you're working here and their classification says one thing, but they need something else, but we have a solution. That in a minute. So all of the inmates are classified usually within 24 hours. So level 1 is the most severe, and I've only seen it used once ever. That is for somebody who murders somebody actually at MDC. You become a level 1. Luckily, only one, I've only seen that once. Level 2 is for inmates that require restricted housing units and the strict RHU units, not the ones that are, we also have one RHU unit, but the non-PSU RHU, they come out in 4 points and they come out by themselves. So a high level of restriction. Level 3 is our most common, and it's used for inmates with violent charges, but no violent history at MDC. So aggravated battery, deadly weapon, be a level 3. And then level 4 to 6 is for non-violent offenders. And these are inmates that can be housed in an open dorm setting. And like Dr. Toan was saying, is these patients are like our patients today, but your patients tomorrow, or your patients yesterday, my patients today, they go back and forth. You know, I'm hoping now you can read our notes. We see all of your notes. I was just reading notes on a patient that's like 33 years old, all the way back to his child clinic days. We have a lot of patients that go back and forth, and a lot of these are these level 4 to 6 patients, because you have to imagine a patient with schizophrenia on the street, the police says, hey, you stop, come over here. What do these patients do? They head the other way. What do they do when an officer touches them on the arm? You know, they end up with resisting arrest, eluding, they ran away, these low-level offenses. So the classification is important for us to know, because if we're looking at to clear somebody from our unit to the rest of the jail, we have to know what kind of risk that they have. So each different unit has a different level of risk for completed suicide, for assault. RHU has a much higher rate of completed suicide. And the level 3 pods are really dangerous for our low functioning people. So our solution is that we have these units that can be mixed classification. Now I say that we don't just throw all these classifications together. This isn't a meeting with classification, but any classification can be on our unit. But let's say we had a level 2 and they want to be on our unit. They still have to be restricted. They still have to come out in 4 points. They might have to be start coming out alone before they start, and prove that they do well before they don't join in any groups. But the great thing is we have a weekly classification meeting, and we're able to, if we can show that they're not aggressive, that they want to participate, they're doing better with treatment, then they do allow them less and less restriction. We get their, it's called their red status removed. That's if they were assaultive to somebody in here. And then we get their 4 points removed. And then we get them to come out with other people. And then we step them down to a different unit where they're out with everyone. And this happens very frequently. So I will tell you, before we were doing this, people were just getting stuck in this high-level security status, and we were having a lot of decompensation and segregation. So by doing this, we're able to put people that may be a level 3 inmate on a safer place, like our Fox 2 or our Delta 3, where we can keep them from being harmed. So the PS units are stratified by classification and security risk. You know, if we want to move somebody to our unit, like I was saying, they're the highest level. They've got to go to RHU to start. But classification, the deputy warden, the major, the captain over our units, they want to see people go from RHU down to Fox, down to Delta, and this is for the men. They want to see people move on. We've only got, I think there's one person right now that I agree with them, cannot move on because he's a predator himself. So the big thing that we gained this year is we got unit Delta 3. It's a dorm style unit, so there's no cells. So when we're sending people from Suicide Watch out from PAC, sending them to this unit is the safest option. And I've got data to back that up. So it's also a bigger unit because we've got our 30% increase. So it has allowed us to house more people that just should not be in general population. So I put on here some of the data from the Suicide Prevention Committee. And if you can't read all of this, I've got slides that are closer up. So the things that we track are the days incarcerated prior to the event, where the event took place, were they already opened a PSU? Did we refer them to the M&M committee? Were they an ER send out? Did we have to do a corrective action plan? And then we track all of the reasons why they self-harmed. So you can see from this, 50% are in the first week, and almost 50% are in the first 24 to 48 hours. And then still in the first 2 weeks, you have the majority of these suicide attempts or self-harms. And then we see this kind of pickup at 31 to 70. We do see people that really try and kill themselves. They find out they're not getting out of jail. They found out their crime is worse than they thought. They see themselves on the news. You know, their crime is terrible. So we'll see that go back up a little bit. But the majority is that first week. And then we look at the units this happens on. And we're going to have self-harm on our psych units. And on our psych units, we have good observation of these people. I highlighted these units that are non-psych units, Route 3, Route 7, as problem areas because they don't have, again, the kind of observation that we have on our units. And these are intake and detox units. Fentanyl withdrawal is terrible. And then combining that with their charges, we have a lot of self-harm, and we've had our last completed suicide attempt was on RHU 3. And there's been several on that unit. So again, if you're working here, like Dr. Toan helping us on the weekend, and you're thinking about sending somebody out, you need to know the relative risk of all of these different units. And that's not something that we expect somebody to know in the first week or month. It's something that happens over months, which is why we send you to these different units, and so that you can have the awareness. We also do like a checkout if somebody is new about where they want to send people to make sure that it's that we think about the risk. Mostly we're sending our patients to our own units. So there's also the type of event and the secondary gain. So it's the same as the notes I see at PES, where somebody comes in, you're seeing them because they say I'm suicidal, and then what they really want is a sandwich and a blanket. Sandwich, blanket, and then they're released. We see that a lot here too. We see people that malinger, they put things around their necks, they make little cuts, because a lot of times they're unhappy with their placement, but a lot of times they're not in the right placement. What if we miss them at intake and they end up on a general unit and they're being victimized? They frequently don't say, hey, I'm being victimized. They say, I'm suicidal. It's to get our attention. We help get them moved. But most of our people on suicide watch are not suicidal. It's actually a fairly low percent. So I wanted to say a word about releases, because this can frustrate, I know, the people working at PES, because all of a sudden they're getting all of these certificates of evaluations, but we're short-term detention. We're not prison, we're jail. And our release is at the mercy of the judge. So sometimes the attorney doesn't think the patient is getting out. We don't have a discharge plan. We don't think they're getting out for months. And it's like, oh, they were discharged. They were released by the courts. And we have to send them. And then we have a lot of releases that happen, at 72 hours. They come in, they see the judge, they get released, their paperwork is filed, and they're released the next day. We only can keep them for 24 hours, and we need to have a good reason to keep them for 24 hours. So what we've been trying to do is send their certificates to get, like in the morning, no certificates at night. But depending on when they were released, like if they were released on Saturday, we have to send them on Sunday. If they were released on Sunday, we hold them till Monday. But then what happens is instead of getting one certificate, you could get, say, 4 at a time. And we just don't have control. And as an example, one of our terrific discharge planners has this elaborate discharge plan for somebody to be released on Wednesday. And part of the plan was they go to the CTC. Now, I understand that's not a guaranteed bed. We had backup plans if they didn't get into the CTC, but there were beds at the CTC. The mother's coming from out of state to pick this guy up and take him back to Arizona. This elaborate plan. Well, everybody said he's out on Wednesday. Wednesday happens. It looks like it all went well in court and he should have been released. He's still here. He's still here. I set up a plan for somebody because their release they said it was going to be, last week, a certain day. He didn't get released. He stayed. Well, he's still here. So, but, so we make our best plans. And then one of the things with UNM is, we have the bridge clinic. So when people are released, there's a place we can send them to for their medications, for their long-acting medications. And then also we send them for their Suboxone. So we have a place to send these people, which is terrific because then they're not walking in all the time at PES. So I just want to say one thing, and then Dr. Toan, I know that do I have 5 minutes?
Yes, you do.
Okay. So I just want to say a word about House Bill 8 because it's new. It's a new law, and it went into effect June of this year, June 20th, for patients found incompetent but not legally dangerous. So the patient could actually have been assaulting people. They could have assaulted people 10 times, but they didn't murder somebody. It wasn't a sex crime. They didn't burn somebody's house down with them in it. So they're not dangerous under the law. So what happens is the DA then asked me and now Dr. Shed what we think about what this person qualifies for. They qualify for civil commitment or AOT or neither, and they should be released. So the DA files for the civil commitment, and then I've testified, Dr. Shed has testified, and I got really excited about this because the first case that I had, I was successful. He got a 30-day civil commitment. And then when it was determined how long we were going to leave him in jail before he was transferred, as soon as the special commissioners found out that our wait time at that point was 12 to 15 weeks, they were not willing to do that again because if they granted the civil commitment, in their mind, they were extending incarceration. So there's been thought into how we can do this. Like Dr. Shed has talked to the staff at the state hospital, and we're still considering, because lots of states have a law like this where the jail can actually do the civil commitment. It prevents me from sending them to the hospital and then you at the hospital having to do it. or they're not qualifying, they're getting out and they're coming right back. So we will continue to seek civil commitments. So you may see people on certificates, and we'll be talking with the staff directly if they have a civil commitment. That's just one thing that's already done. And so if they were admitted, they're already on the transfer list to the state hospital. To me, it's an exciting move in the right direction. So just to close, one of the psychiatric residents asked me during an interview what it takes to work here, what kind of person lasts a long time. I've been here a long time. Dr. Ide's been here for 16 years. Before Dr. Rousseau was here for 15 years. And like, how did we do this for this long? And you have to really have some determination that you are going to treat these people. Because in the jail setting, there's just more barriers, but you can get it done. And you have to be always educating security staff and all people and advocate for the patients. It's just a regular part of our life here at MDC. Thank you. I can stop there, Dr. Toland.
Thank you, Dr. Hamilton. I must say that I learned a lot today. Uh, Thanks so much. So I would, what do we, not first question, but more of a request. As mentioned, we are a team. If you can just, especially those who deliver care at PS or inpatient, what would work? What would make our team work even better to take care of our patients who we share? Any comments that you would make for those of us who are at times at PS or even inpatient? Dr. Hamilton.
I think, and we talked about this in the PES meetings, to realize that the people we're sending on a certificate are such a small percent of our actual releases. Like, we are only sending the people that we haven't been able to start treatment. And in our minds, because of their past, they're just going to get rearrested if they're not stabilized. And I mean, of course, some of them we send on certificates, they're just mad about jail and they go over and they're fine and they're released. But in general, that's our consideration. If something isn't done, they're just gonna assault their mother, husband, sister, brother, officer again. Like this, nothing has been changed. It's just gonna happen again. And that it may seem a lot to the people at PES because you've got all the other patients, but it's just very few percentage-wise that we actually send.
Thank you, Dr. Hamilton. Questions, folks? Either raise your hand virtually or physically, or just throw in the question. Dr. Quinn.
Hi, Dr. Hamilton. I appreciate you taking the time to educate us about MDC, just like, you have a role in educating all the staff there, and it certainly helps us do our job, better and to be able to work smoothly with you all and your staff. I guess the question that I have is, uh, I think we're sort of recognizing that there's some patients who may uh, amplify symptoms because they don't like where they are and they want to sort of, not be there. And that poses a challenge for your folks and ours. And to what degree do you all sort of see antisocial personality, sort of be able to identify it, risk stratify around it, and sort of how do you sort of conceptualize patients who are predominantly there because of antisocial personality disorder versus people who are there with sort of SMI, and what can you say sort of what happens with those folks generally?
So one of the things I didn't do is like list all of the units of the other part of the jail that are not ours. And that's like unit Echo 1 through 8, the other Fox 1 through 8. So, and there's a lot of the rest of the jail. So if you went on a general level 3 pod, it has career criminals, gang people. So they kind of self-segregate. But of course, we have a lot of people who have high sociopathy that also have mental illness. We tend to have some schizophrenics that are highly sociopathic. We have one, he's been here 128 or something times. So it is a problem, like on our units, the same as the inpatient units. If you put somebody with high sociopathy around everybody else, they victimize people. You hope it's just stealing their food, but of course here they steal their pins, they steal their money, they, are violent. So we move them off of our unit or to a higher level of care. But part of, yesterday I saw 7 people. 4, it was all just about malingering because they didn't want to be locked down, but they were locked down because they had assaulted people, they had done all these things. So I just say, well, I'm not letting you out either, and send them back. So there is a process here because it's so prevalent.
Great. I appreciate that. Thank you.
I have a quick question, if we have time.
Sure.
I was on the inpatient consult service this week, and we had a patient transferred from a jail in outside Albuquerque because the judge had ordered a forensic examination. And so, it's not really something that we do at the university service, but I was curious if you ever do those kind of forensic evaluations for other jails in New Mexico.
So we do have, there is a contract that other small jails can get to transfer their in-custody patients to MDC. And then they can be on one of our psychiatric units and they could do the evaluation here. So we get those from Sandoval, we get those from Valencia, and it can be done anywhere in the state as long as we have the capacity. So that they could, because that does seem like a huge waste to put them there and not here. Were they from a small county?
Yeah, I was actually from one of the pueblos.
Yeah.
That's good. Thank you.
That's a very interesting point. Thank you for the question, Dr. Wiley. And again, it highlights the uniqueness of MDC. Dr. Hamilton, thank you so much. And again, we admire the amount of work and dedication that you have to your inmate patients. Thank you so much, folks. Have a good weekend.
Thank you.